I'm Shelley Cohen-Conrad. I'm the director of the Interprofessional Education Collaborative, which is a group of faculty, administrators, students, staff, community members who come together to think about ways that we can all work together for better health outcomes, patient safety, and quality care. And I want to tell you that part of our initiative this year is not only these events, but attached to these events we are going to be offering service learning opportunities. And if Tricia Mason can raise her hand or stand up, those of you who are interested in service learning projects that will be attached to these, we will have homeless outreach. We will be working with the Riverton Park community. We will be working with the Cumberland County Jail. We will be focusing on partner violence, prevention and support, and there will be many other community opportunities. So if you are interested, please see Tricia, and you will be seeing more announcements about that as we go along. I also want to encourage those of you who are interested in becoming part of the interprofessional student advisory team. The students advise us about what you want us to be producing here at the university. Who here are on the IPSAT team? Can you raise your hands and make yourselves known? Over there. Please find our IPSAT students and sign up, because this is for you, and we want to get your input about what you want. So great. Okay, enough with the announcements. It is my pleasure to introduce Dr. Dora Anne Mills, who has told me not to say very much about her. I could actually spend about a whole conference doing that.
I have a hook.
She has a hook, and she will use it. What Dr. Mills wanted me to tell you is that she was born in Farmington, Maine, and although she has traveled the world and she has studied all over the United States and abroad, she has chosen to settle here and raise her family and work here in the state of Maine, on this campus. Dora was for 15 years the director of the Maine Center for Disease Control and the state health officer. She is now here with us in 2011 as the vice president for clinical affairs, and most recently the director of public health programs. She is a huge advocate for all the work we do around collaborative care. We have come to work together and know each other, and it is my pleasure to introduce you.
Thank you very much. Thank you. And actually, I am just a preview, because we are very fortunate today to have a wonderful guest here, Lisa Sockabasin, the head of health equity and minority health for the state of Maine. I just wanted to share with you first how I kind of came to recognizing that health disparities are a critical issue and actually should always be our focus if we're working in health. And that is, having grown up and working in rural Maine, grew up there and worked there earlier in my career as a pediatrician, I was not that aware, I have to admit, of health disparities. And of course, years ago, there wasn't much awareness around at all about health disparities. When I came into public health and went to work at the Maine CDC, the idea of health disparities had just emerged, and we were talking about it and discussing. The federal government had made it a priority. We were talking about it here in Maine, but we were struggling, because while there was some data nationally showing how some populations, not due to biological reasons, but for other reasons, are disparately affected, their health is disparately affected, we didn't have a lot of data here in Maine to show that, particularly around race. And so it was a tough time, because we couldn't figure out how do we prove that health disparities exist in Maine, how do we talk about it in Maine. And in 2002, we were charged with writing up a state health plan for the decade called Healthy Maine 2010. And I actually went on maternity leave for 6 months that year, so I spent quite a bit of time working with Sharon Leahy-Lind from the Muskie Institute, and we worked with partners around the state to put together this plan. I mentioned maternity leave because I was able to have some freer time, so to speak, to work on it. And we got to health disparities, and we couldn't figure out what to do because we didn't have a lot of data. So, but we also knew that we needed, in our state health plan for the decade, we needed to address health disparities because we knew nationally the data were so compelling. So what we did was we took the data we had, which wasn't a lot, and we worked with partners around the state and statewide stakeholders to come up with 8 populations that we thought were important in Maine that we felt were experiencing health disparities. They were first and foremost racial minorities, racial and ethnic minorities, people living in poverty with low socioeconomic status. Also then we had 6 others. So those were the 2 core, and then we identified people living with disabilities and gender, both male and female, experiencing disparities, sexual minorities, the LGBT community, veterans. It was right after 2001, after 9/11, and we found out that Maine had the highest rate of percentage or proportion of people who were veterans, and we had just throngs of people going off to the war, the new war back in 2001 and 2002, and so we identified veteran status, also age, and we particularly focused on adolescents and elders. And I'm trying to remember what the other 2 were, but anyway, I'm forgetting. But we identified 8 total, and since we had some data for some of them, but not a lot of data for most, we put together a booklet. We decided to do it as a second volume. I'll show you. Here was the state health plan for the decade, Healthy Maine 2010, and we integrated health disparities into each chapter in this as much as we could. But then we also wanted to really call out health disparities. So we did a second volume that came out at the same time, Opportunities for All, which was focused on these 8 populations. And because we didn't have good data, and this is something you deal with in public health a lot, we decided to go to some key informants, some people who work with populations who were coming from those populations facing disparities, and interview them. So Sharon and I split up the list, and because I was home with an infant and a 3-year-old, I did most of those interviews by phone. And what I learned really changed my life. What I heard were stories from people who also grew up in Maine and had very different experiences than what I had. People who told me how much they feared the healthcare system. People who told me how much they feared people with badges and uniforms because they meant something different to them than they had meant to us, to me. Sorry. And when I got off the phone one time from a woman who was French-Canadian descent, I turned and told me she had told me some very similar stories. I turned to my husband. My husband's Italian-American on his dad's side, so his last name is Italian, Fiore. But his mother's French-Canadian descent from the St. John Valley. She was a pelletier. And I said, well, you know, this person I talked with told me these experiences that she had growing up as a French-American in Maine. I've never heard you say anything about that. You didn't have those experiences, did you, or did you? And he says, I don't talk about it, because it was a very tough experience for him. He grew up in Brunswick, and there were a lot of French Canadians living in Brunswick, including a lot of his relatives. And they hid the fact that they were French American because they had an Italian last name. And he told me about how his mom was so fearful about going to the doctors, and she wanted to make sure that healthcare professionals respected them because she had had a lot of experiences where they didn't. And so she would dress up the kids. If they were just going to get an ear infection check or something, she would dress the kids all up in their Sunday best, even if it was a Tuesday morning. And I said, you know, I remember being in Farmington and practicing, and I remember seeing people come dressed up as if they were going to go to church or something, and I thought, well, maybe they're on the way to some place that's you dressed up for, because I never thought to dress up to go to the doctor's office or my healthcare provider's office. And he says, no, you do when you're concerned about how you're going to get treated. So during those interviews, during those few months, I learned a lot, including from my own husband and his own experiences. And it also changed the way I looked at the data, because the data tell a very compelling story. And the stories that I heard also fit the data. About 4 years later, we were very fortunate that we had some legislation that had been introduced to create an Office of Minority Health in the state of Maine, located at Maine CDC. And I can tell you, in my 15 years at Maine CDC, the best hire we ever made was Lisa Sockabasin. Lisa Sockabasin comes to us from Washington County. She grew up in Washington County. She is a nurse. And she came to us in 2006 to start the Office of Minority Health. And her office was fortunately located next to mine because I had a lot of questions. I didn't know what to do. We knew from the data we had and the stories we collected, this was a huge issue, even in Maine, and even sometimes especially in Maine. And we weren't really sure what to do and how to do it. And she basically has guided Maine state government to some degree, but particularly public health in Maine, as to how to address health disparities. And it's with tremendous honor to introduce to you Lisa Sockabasin.
Thank you, everyone. And I can tell you, she is telling the truth when she said she had a lot of questions. And you know, it's funny because I have a lot of questions about this work too. And I think I learn more and more when I talk to groups like this, and the insights that you all have on these issues, I think, are really what's most valuable when we actually talk about these issues around health disparities. And as Dora alluded, some of the issues are really difficult issues. They're issues of treatment or discrimination, sometimes racism, and some of those things that oftentimes don't come up in the classroom when we talk about delivering health care to groups of folks. So I'm going to start first with a film, and it's only 4 minutes of a clip, and I just want to ask real quick, from just a show of hands, how many of you have either heard about or watched a documentary series called Unnatural Causes? Not very many. How many of you have not heard of or seen Unnatural Causes? There's a lot of you. So one of those things, I will give you at the end of this talk some things that you can do as individuals to understand this field of health disparities and the emerging research that's going on in the field. But I really encourage you, when you get back to your homes or the library, you look up unnaturalcauses.org. It is an amazing series that was released about 3 years ago that really highlights those root causes of why we're seeing these differences in not just health in populations, but actually the difference in terms of the care we deliver to certain populations. So
there's something unfolding here in Greenville and All Mountain County that might have been what Dickens was talking about when he said the best of times is the worst of times, because we are having an economic boom in some sectors. There are new houses being built here that makes it into a bedroom community for some large areas around. We have had some national franchises move in here and build significant buildings here. At the same time, there's this loss of jobs in West Central Michigan
So this is the wrong clip. So let me just find you the right one. 1 second. Here we go. Let's try this one. I'm just trying to tease you and all the other things you can say. 1 second. All right, here we go.
There's one view of us as biological creatures, that we are determined by our genes, that
there's something unfolding here in Greenville and All Mountain County.
there's one view of us as biological creatures, that we are, that what we There's one view of us as biological creatures that we are determined by our genes, that what we see in our biology is somehow innately us because of who we were born to be. What that misses is that we grow up and develop. We grow up as children, we grow up as adults and continue. We interact constantly with the world in which we are engaged. That's the way in which our biology actually happens. We carry our history in our bodies. How could we not?
Living in America should be a ticket to good health. We have the highest gross national product in the world.
I'm very happy to finally have some of my cars in one location, some of them.
We spend $2 trillion per year on medical care. That's nearly half of all the health dollars spent in the world. But we've seen our statistics. We live shorter, often sicker lives than in any other industrialized country. We rank 30th in life expectancy.
Especially of economically developed countries, we are at the bottom of the list.
A higher percentage of our babies die in their first year of life than in Cuba, Slovenia, Estonia. How can this be? Is this just because 47 million of us have no health insurance?
Healthcare can deal with the diseases and illnesses, but a lack of healthcare is not the cause of illness and disease. It is like saying, since aspirin cures a fever, that the lack of aspirin must be the cause of the fever.
Or is it mostly because of our American diet and personal health behaviors?
Those behaviors themselves, in part, determined by economic status. And so our ability to avoid smoking and eat a healthy diet depends, in turn, on our access to income, education, and what we call the social determinants of health.
But wouldn't our genes trump social determinants of health?
Among twins who lived together until age 18, who basically grew up in the same households, so had at least a relatively similar exposure. If they diverged later in life, if one became professional and the other was working class, they ended up with different health status as adults. This is among identical twins.
Written into our bodies is a lifetime of experience, shaped by social conditions and policies that can determine who will be sicker, who will die sooner.
There are ways in which our society is organized that are bad for our health. And there's no doubt that we could reconfigure ourselves in ways that would benefit our health.
There are huge inequalities in the society. All this wealth is maldistributed.
Pet food, ice for the pets' water.
And I think that's in part why the US as a whole has relatively poor health amongst the rich countries, and why even the better off people are suffering. And we think that that is not inevitable.
Unnatural Causes. Is inequality making us sick? Coming to PBS 2008.
So what's really interesting, Dora, you might remember this controversy when we were working together, but there was a national effort to show these films on PBS across the nation. And unfortunately, Maine had decided not to air this series. And we can come up with hypothesis why. One of those is around funding. It's expensive to air these films. But I'd like to think also that oftentimes we don't think that Maine is impacted like many other parts of the nation when it comes to unequal treatment or disparities. And oftentimes, people in Maine that I've run into really truly believe that discrimination or differences in the way people are treated actually are not that great. So I want to present to you some information that we know nationally about bias in terms of our healthcare system and the lack of trust and what we can do about it as healthcare professionals, as well as faculty and as an institution academically. So here we go. This is what we're going to go over today. We're going to share some evidence for the existence of health disparities, and I will provide you with some national data that you probably are fairly familiar with, as well as describe some factors that contribute to health disparities, both health disparities and healthcare disparities. We'll provide you with some solutions to improve the quality and to reduce disparities, and share some tools that may assist you in your careers moving forward, and things that you may want to be aware of when you see patients. So why didn't anyone tell me the slideshow isn't going? There we go. There we go. Okay. So, we could spend time, there are people who give talks that basically have to justify to the entire group, which is what we had to do with the legislature when trying to prove that we needed an Office of Minority Health or an Office of Health Equity to focus on these issues, that there are really challenges and there are issues that's supported by data. So I'm not going to spend a lot of time with you all telling you disparities exist and prove that to you. There are volumes and volumes of research that actually support there are differences that certain populations face when it comes to their health outcomes. So something from Health Affairs, this was back in 2002, and when you see some of the other research that's more recent, unfortunately we haven't seen the gains that we want to truly see. And in the United States, there's a 20-year gap in life expectancy between white men in the healthiest counties and black men in the unhealthiest counties. And so what we're seeing nationally is that we are seeing this disparity in life expectancy. And my question to all of you, and you can show with a show of hands, is how many of you think that that we see drastic differences in life expectancy here in a state like Maine? Some of you? Okay, we'll go into some of that Maine data, and I can show you which communities or populations are actually suffering, living far less numbers of years, as well as unhealthy years of life. So overall, and this is in 2007, the National Healthcare Disparities Report, again, another document I encourage you to take a look at. Basically what it was showing after decades of data is that disparities in quality and access for minority groups and poor populations have not been reduced. What we do see, and we know disparities does not just occur with racial and ethnic minorities, it occurs with people who are living in poverty, low educational attainment, veteran status, women, people living in rural areas, GLBT, and the list goes on and on, people with disabilities. So what we know is that the incidence of certain illnesses are decreasing. So we know infant mortality is decreasing in the African American community. And we also know it's decreasing in the general white community as well. But what we see is that the gap between black and white is actually increasing. So we see a decrease of infant mortality, but we're seeing this increase, this black-white ratio actually increase. So we need to do more work in terms of trying to develop solutions that's going to address those issues. So eliminating disparities. So as I alluded to, there are disparities in health, which is the differences between populations, and then there's the disparities in health care, which basically states that there are differences in the way we treat patients based on what group we may see them belong to. And we'll talk a little bit more about that as we move on. One of the big areas of health disparities, you cannot talk about health disparities without talking about the social determinants of health, those factors that contribute to our health status that oftentimes are far greater predictors of our health status than whether or not we have insurance coverage or we have a positive relationship with our healthcare provider. Those things being our educational attainment, oftentimes people say is our number one predictor of our health is our level of education, as well as what our paycheck says, and our level of income is, again, a very big predictor of health. We're going to be focused more today on very briefly what the social determinants are, as well as some of those other things that we often don't talk about, which is the level of trust we have with our patients as well, or the communities if we're in public health, or as well as our implicit biases that impact the way we talk with and communicate with our patients or communities. So nationally, just some statistics. These are not going to surprise you. Infant mortality rates, as well as deaths during or complications during childbirth. Big disparities between our African Americans as well as our Native Americans and Hispanics when it comes to racial differences in these two areas. Now, disparities have been recognized in many different groups, as I mentioned, but most of our research has been focused around differences between Black and white. And some of those reasons are the way we collect data. Dora had mentioned that we don't have data on certain populations, and some of the reasons for that is that we often collected data decades ago just by Black and white, and even before that, it was slave and non-slave is how we categorize people. So we've gone through this tradition, or this this process as a nation in terms of how do we categorize groups of people, and what does that say about what policies we have in place if we're basing our policies and resource allocations based on the data that we have, and not asking the questions, who do we not know a lot about, and how would that change the way we make decisions? So in Maine, I wanted to give you some sort of picture of what we're dealing with in Maine in terms of racial and ethnic disparities. I talked about life expectancy briefly, which is a good indication usually of disparities in a particular population. When we look at the tribal populations, the native populations in Maine, I'm from Indian Township, which is a Passamaquoddy reservation, very far from here in Washington County. And what we know about that population is that their life expectancy is barely 50 years old. So I can expect, based on my background, to live until I'm 50. What we also know about the other tribes is they don't fare that much better. That ranges until the mid-50s for some of our tribes in Aroostook County. So we have 5 tribal communities in Maine, 4 federally recognized tribes, each with their own life expectancy, but all of them far less than 20 years is what we see, mid-70s what we see for the general population. So what is going on there with that community, and what can we do to learn more and address some of the root causes of their problems, and not just tell them that they need to eat more fruits and vegetables and exercise, right? It's not all about education. It is about the conditions that people are living and working in, and their power and control may be very different than some of us in the room that have access to other resources. So contributing factors, of course, the health system plays a huge role in both contributing to disparities, but also helping to address disparities. I will say that there have been many bills nationally that have been passed that have supported more research through the National Institutes of Health, as well as the Department of Health and Human Services and other agencies, to really look at these issues and really focus in terms of their funding on our most vulnerable people in the country. Patient level factors, we talk a lot about, well, we could address these disparity issues if patients just took responsibility and did what they were supposed to do. We know that, yes, of course, responsibility and patient adherence to certain treatments is important. However, it does not tell us the full story, and often other things are larger contributors than just whether or not you adhere to treatment. And we'll talk a little bit about disparities arising from the clinical counter as well. So really quickly, the social determinants of health are the conditions in which people are born, grow, live, work, and age, including the health system. Basically, we are products of a very much larger system. We're impacted by our communities, whether we have sidewalks to walk, whether we have good grocery stores to go to. And so, and as well as do we have access and equal access to education. Another film that I would encourage you to watch, which we won't be watching a clip, is Waiting for Superman. Who's seen Waiting for Superman? Quite a few. I encourage you to take a look at this film, which talks about access to education and the disparities that we have in this country around access and how that contributes to our disparities, both in income as well as health as we move forward. So trust. There are many public health schools across the country that really are starting their curriculum and focus, and even their orientation when public health students first come into school, around building trust with communities and how vitally important it is to improve the trust that we have in working with communities, as well as patient-provider trust as well, and how that may or may not contribute to disparities. And so we know that there's a high value around trust, that patients are more likely to adhere to the recommendations their provider is giving to them if they trust their provider. We also know that decreased trust has been associated with, lower satisfaction, increased demand by patients for referrals and diagnostic tests, feeling that they're not getting the quality of service they should be receiving, increased litigation, and also lower health status. So in building trust, there are many best practices for this in the clinical setting, and I can provide Dora with some of those resources, and hopefully you're able to take a look at them and see how you would do things differently in your encounters with patients. So we must be addressing this issue around trust and why we have a general mistrust. It was an interesting story that Dora told us about her husband and going to, the doctor and perhaps not having the best encounters with that provider, thinking that if I dressed better or looked better or didn't look like I belonged to a certain part of, a community, then perhaps I'll get the same level of care as other people who do not belong to that community receive. So here are some general questions that was asked, funded through the Kaiser Family Foundation, and what we're looking at is, and I'll read you these questions because it's very hard to see. Do you think the average African American is better off, worse off, or just as well off as the average white American in terms of access to health care? And what we saw is white Americans suggested that 35% of white Americans suggested that, yes, I do believe that, there is a difference here in terms of access. And what African Americans are suggesting is that a larger percentage of African Americans suggest that there is a difference in terms of the health care they receive and their access. Another question, how much discrimination do African Americans face in our society today? 20% of white Americans said a lot, 48% of African Americans said a lot. So we're talking more than double of the population that has historically been, unfortunately, recipients of discrimination show that their trust and their level of comfort in the society is definitely different. So this is what we know. African American men and women are less trusting of hospitals, less trusting of their providers, as well as their therapies that are suggested to them. less trusting of the organ donation system, which I think is really interesting. And I'll show you I think it's a 90-second clip that talks about that a little bit, and we can hopefully have a small conversation of why that issue around organ donations in African Americans is such a difficult issue. African Americans have less trust in the healthcare system than in general. And so there's also a profound mistrust of medical research in minority communities for all sorts of reasons. And they also minorities tend to report more communication and poor communication with their providers. So again, some more data for you, and then I'll show you a small clip on a patient's experience with kidney dialysis, actually. We see that when we ask the question of all physicians, believe that the healthcare system treats people unfairly based on their racial, ethnic background, very or somewhat often, what we're seeing is 77% of African American physicians believe the system in which they work still treats people differently. That's compared to 25% of white physicians that believe that this still exists. So again, I'm going to transition into a short clip.
In the African American community, Tuskegee is a big part of our experience. I mean, it's a number of things, but it kind of is a more recent and poignant experience that a large segment of the African American community is familiar with, and has colored it, particularly for a generation of African Americans, has colored their behavior when it comes to medicine, right? And that generation just implicitly doesn't trust doctors. Most of the patients here either have had transplants or are going to have transplants. Most of the African American men here aren't. They're kind of in it for the long haul. I know there's research to back that up, a lot of quantitative research to back that up, but anecdotally, there's a big disparity, a big disparity. And a lot of folks voice it, particularly in their despair. You can hear it. I mean, when they talk to the nephrologist, they don't like talking to the nephrologist because the nephrologist only has bad news.
How many people in the room have heard of Tuskegee and the experiment? Quite a few. So there has actually been some research with children around Tuskegee. And what the thought of is that, as this patient said, Tuskegee really colored a whole feeling of distrust that the population had for the healthcare system. Basically, not just the healthcare system. This was a study that was conducted for 4 decades, 40 years. By who? Who was it funded by? US government, right? The Public Health Service. And so not only does your trust not support you in thinking you're going to seek good healthcare or get good healthcare, receive good healthcare, but it also colors your viewpoint on how you may think about government and how you may think about the treatments that your physician is, suggesting that you go through. So we know it began in 1932. It didn't end until 1972. So approximately 400 African American men in Alabama with syphilis were observed by the time of diagnosis to autopsy. So if it's untreated, you die. Most received ineffective treatments, and even after penicillin was available, widespread in the 1950s, still treatment was withheld for these men. Patients were not told of their diagnosis. They were told they had something called bad blood, but were told that they would receive free care. What a benefit, as well as a burial stipend. Patients remained infectious during their whole course, underwent lumbar punctures and other invasive treatment. It was in 1997 when President Clinton made a formal apology to these men in the community for what the US government was responsible for. I will tell you that, yes, this one experiment that lasted 40 years absolutely colors many different peoples, not just African Americans, but anybody who has been in a group where discrimination and bias has been a factor for them. It colors all of us in terms of our trust with both the system, the healthcare system, and the government system. So these are some of the comments that much has been done in the area of trying to understand what people's thoughts and beliefs are around the healthcare system and government after Tuskegee, post-Tuskegee. You know, in the 90s, there was great debate in the African American community and minority community in general that the AIDS virus was deliberately created in a laboratory in order to infect Black people. So 30%, and this was, as I said, back in '99, 30% of African Americans at that time believed that this was true or that it might be true. So had some belief that AIDS was deliberately here to infect them. AZT is a plot to poison our African American people, and urging condom use is a scheme to prevent African American births. And I understand where that comes from when I think about my own community and family experience and think about how common sterilization techniques were used in the American Indian community to stop American Indian births from happening. So I'll read you one quote and we'll move on from here. Well, this is just my opinion. The population is growing. People are dying at slower rates. So they said, let's see what happens if we infect this HIV out there. Another statement, I think experimentation on Blacks is still going on. Like AIDS, it was man-made, but it kind of got out of hand. Go through here. So disparities in the clinical encounter, it's really interesting. I'm going to ask you all this question and really think about it. How could well-meaning and highly educated health professionals, like all of you, working in their usual circumstances with diverse populations of patients, create a pattern of care that appears to be discriminatory? We go into this field to help people. We go into this field to make a difference. So how does this happen? So looking at stereotyping and bias and implicit bias, there are volumes and volumes of articles looking at stereotyping and how our personal biases come into play when interacting with people each and every day. Or making a decision, say, as a public health agency in terms of what projects they're going to fund. So stereotyping is a process in which we use to categorize people, and it was used as defense or protection to help us make snap decisions on different groups of people. And this, of course, is continuing not just with all of us today, but there's evidence that suggests that physicians, like everybody else, have these cognitive shortcuts. And how do we address and identify what our shortcuts are so we can ensure that we're providing culturally and linguistically appropriate care to every patient? So what we have seen is that in clinical settings, doctors are more likely to ascribe negative racial stereotypes to their minority patients. These negative stereotypes to their minority patients were still there even when accounted for education and income. So even our minority patients that you would think that have sort of beaten those other social determinants of health and become educated and have high educations, they're still seeing this issue around negative stereotyping. So This is a book that I also want you to become familiar with. It's called Unequal Treatment, Confronting Racial and Ethnic Disparities in Health. This was issued back in 2002. It's an Institute of Medicine report where hundreds of research studies were analyzed, and basically what the study committee found is that there is evidence of stereotyping biases and uncertainty that healthcare providers have, and it does contribute to disparities. There's a 1 o'clock class. Okay. Okay.
I just didn't want you to think people are like bored.
Not a problem. Okay. So what they found in this lit review of all of this research, that oftentimes minority patients were viewed by physicians as being less intelligent, less educated, less likely to comply with their advice, and more likely to have problems with alcohol and drugs. Physicians also rated minority patients as less likely to be the kind of person whom the physician could have as a friend, which I think is really interesting. Rated minority patients less likely to be their friend. And we also know that pain management and the withholding of pain management is something we've seen in every other racial and ethnic minority population, that we see non-minority patients receiving higher levels of pain management than minority patients. So this issue of implicit bias, they are pervasive. People are often unaware that they have these biases. Ordinary people, all of us, have negative associations, in relation to various groups because of our life experiences. We are products of our environment. So what can we do about them? This was a study done in the 90s with University of Washington and Harvard Medical School, where they looked at patients, fake patients, basically, and what they saw after they screened physicians in terms of what they would recommend for these patients in terms of care. They saw that blacks were less likely to be referred to cardiac catheterization, even when it was recommended, as well as black women were referred the least to these specialty services. Because of this research, became a great focus and really a new field, really talking about implicit bias and cultural outcomes and how that impacts. And what we found is that the implicit association test really helps us identify our own personal biases with certain groups. So yet again, another thing that I think you all can do is to go onto Google, search the implicit association test, and really look at the tests that you can take to explore what biases you may hold. I've done it. It was enlightening. I've had my colleagues do it. And it's a little shocking in terms of what it may pull out for you. And bringing those biases more to the conscious of your mind does impact the way that you work through those biases when you're encountering them. So this is a screenshot which you can't see, but I will show you one last film and close hopefully for comments and questions, and talk about hopefully what you can do as individuals as well as what UNE can do as an academic institution. So this is a screenshot of what you will see when you actually go into the implicit bias test, but I will go into, I will go into the film so you can see the actual, how did that happen? I don't know. Okay. So this research generated a lot of attention through all the news networks, through journalists that really wanted to look at implicit bias and see how certain groups reacted after learning what those biases are. Some people welcomed the biases that they had, and some people were a little bit less willing to admit that they may have biases. So we will play that for you and then hopefully go into questions.
That we are not racist, but could we harbor prejudices that we may not even be aware of? A few years ago, we showed you a surprising scientific test that can reveal hidden racial bias. It's a test worth looking at again this week. Here's Sarah James.
I want to take a moment to apologize for an insensitive and ill-conceived remark we made.
While Don Imus has apologized for his racial slurs, he insists he's not a racist. But is it possible that virtually all of us have a hidden racial bias, hidden even from ourselves? Several years ago, Dateline brought together two groups of volunteers, African American and white, who agreed to take a test scientifically designed to answer just that question.
Here's how it works. These words and faces appear rapidly, one after another, around the screen. The test taker is supposed to link one to the left or right box here in the center, linking positive words like friend to good, negative words like awful to bad, white faces with white, black faces with black. And it's the mistakes that are so revealing.
We find that frequently. Some people are disturbed by their results. Ready? Go.
Dateline put this experiment to a difficult challenge, testing a cross-section of men and women, including some who have impeccable credentials in race relations. People like Rhonda, a civil rights attorney.
Okay, I'm ready.
Okay, here it is.
During the first half of the test, black is linked to bad and white is linked to good.
Right.
For Rhonda, this half of the test is a breeze. She never makes a mistake.
Okay, very good. Now, we'll give you the other one.
But let's see how she does when the information is reversed, when the left box, marked bad, has a white face, and the right box, labeled good, has a black face.
Left, left.
Suddenly the test becomes much more difficult for Rhonda. About a third of the way through, she makes a mistake, linking the white face to the right box, even though that shows a black face.
I lost it.
Okay.
Rhonda's score indicates a strong preference for white. Is this because she unconsciously associates white with good?
Well, I could tell when I was taking it, I had so much of an easier time doing the white with good, much to my dismay.
We all might be prejudiced in ways we're not aware. So even
Mazar and Banaji of Harvard University and Anthony Greenwald of the University of Washington created this test.
What do you think this test reveals that perhaps we didn't know before?
how fair are we being when we judge a person?
Okay.
Betsy, an events planner, had similar results.
Left, right.
Once again, on the part of the test which associates black with good and white with bad, a white test taker flounders.
I don't remember.
You held it together almost to the end.
Betsy's test shows a preference for white.
There would be many people who would say, what's wrong with showing a preference for your own race?
In some contexts, it's actually illegal to do so. In employment contexts, in college admissions.
But what does all this prove? Like the other participants, Jeff first took the test individually on a computer, and his test too revealed a preference for white. But he refused the subsequent studio test, saying he doesn't think the experiment reveals anything at all.
I think the test for a person like myself, who has some spatial difficulties and left-right difficulties, is questionable.
Professor Banaji, Jeff is questioning your test.
Well, Jeff's experience is not unusual. Let's say you are having spatial difficulties, or let's say you've never used a computer before. It could easily have been the case that if that was the problem, that we could see a strong preference for black over white, but that didn't happen.
In fact, this experiment has passed scientific scrutiny. And the results of the professor's experiments have been published in leading psychological journals. Our results reflect the professor's findings.
Something like 79 or 80% of white Americans who take the test show a preference for white over black.
And as revealing as those results are, the biggest surprise is yet to come.
Left.
Joan is a sales and marketing consultant. Even for many black test takers, the more challenging part of the test seems to be when black is associated with good and white with bad.
Okay, didn't get halfway through. We'll start over. Okay. Ready?
After 2 attempts, she still can't make it to the end.
I've done it again.
Even so, Joan still thought she'd show a preference for her own race.
Would you be surprised then, Joan, if I said that your test showed a slight preference for whites?
Yes, I would be.
Does it shock you?
Yes.
You're flabbergasted.
I'm flabbergasted.
And Joan isn't alone. Dennis is the leader of a civil rights organization. According to his test in the studio, Dennis is neutral, but his individual computer test showed a preference for white. His response?
All we had in images were whites through the type of media outlets that we were exposed to during my age generation, and that was a constant reinforcement over and over again.
Of the African Americans the professors have tested, 42% show a preference for whites. A large number, especially when you consider that only 17% of whites show a preference for blacks.
Go. Left, right.
And what of the other African Americans we tested? Heather is an assistant district attorney. On the part of the test where the black face is paired with the word bad, Heather has noticeable difficulty and can't finish. She showed a strong preference for African Americans, and her pride was unabashed.
This made me feel more comfortable knowing that I've embraced my culture.
Randolph, a high school music teacher, also showed a preference for his own race.
Does it concern you at all that you have a strong preference for African Americans?
Does that score mean that I do not like European Americans? No. Is my subconscious aware of the condition that African Americans are in this country at this particular point? My conscious is.
According to the research, 48% of African Americans have a preference for their own race.
That's exactly what it comes out as, a strong preference for blacks, and it doesn't
The professors note that there's a difference in reactions between blacks and whites when they find out they have a preference for their own race.
Of course it bothers me, but
You could say it's pride or prejudice. What blacks consider a badge of healthy self-esteem, many whites regard as an embarrassing revelation.
when I did poorly on the black being good, is it because I can't come to say that I'm bad? And is it just in our nature that there has to be an us and a them? And them is going to be the bad guy.
The professors say this test also reveals something else, something more subtle but equally important, that even unconscious racial biases may affect your behavior. For instance, do white teachers unconsciously favor white students?
Right.
Jennifer teaches 6th grade.
Right. Jennifer, your score came out as a strong preference for white. Do you believe that those unconscious attitudes for whites affects your teaching?
I would hope not. I don't view people by what they look like. I view people on what they can do and what they feel and how they are.
These aren't just words and faces on a screen, not just abstract images. This test suggests that when it comes to the potent question of race, our subconscious is making decisions every day. Decisions that in real time, in real life, have real consequences.
This test has now become even more widely accepted. It's available in 19 other countries and 16 different languages.
So just to close with all of you, I just wanted to bring up, now there is something we can do about this. There are things that we can do in the classroom and there are things we can do as individuals. And what we know is that there have been a lot of campaigns, and these, you can't really see them, but they're bookmarks. And I'll read them to you. And basically it has a black face and a white face, two men on the very top, and it says, chest pain, identical symptoms, matching histories, which patient doesn't get the appropriate test? The next one. And these are geared to folks like you, healthcare providers that have to constantly ask themselves these questions. Unconscious racial stereotyping equals unequal treatment. Which patients get the best care? And it shows, again, differences of faces. Two women, same injury, same hospital, same provider. Which patient gets 50% less pain medication at discharge? all of these things obviously proven in many years of research. So again, what we do know is education increases awareness, and then our hope is that changes our behavior. Many studies have been done with medical residents. This is an example of one very small study where we saw some post-education, increases in terms of do disparities exist and why do they exist. So after education, yes, we see this awareness increase in terms of people's biases. So the recommendation, institutional recommendations for hospitals, and we have had a couple hospitals in the state look at bias of healthcare providers in the emergency departments, and it's fascinating to see right here in Maine the same study being done. And basically what we saw in those hospitals, that biases exist, obviously, and what questions were asked were, what are some of the things that you hear from your colleagues about certain groups of people? So we didn't identify individuals. It's what have you heard from your colleagues? What do you think the number one group was that was seeing? It was our Maine care, our people living in poverty for the most part. Another group that was very high? Any ideas? Elderly, not at the top. It didn't fall at the top, but absolutely it was there. People who are obese. It was a real eye-opener for me in terms of this extends so much beyond race. Looking at race and addressing those difficult issues around discrimination can help with these other factors. However, this extends far beyond race. People who are obese and the comments and the way they were treated in the emergency department, people on Maine care, the way they were treated, and also GLBT, especially the T. The comments around transgendered individuals would make you sick. And these are our healthcare providers. What I will say, it's a very brave thing to undertake as a healthcare institution as well as an educational institution, really looking at your faculty, your administration, as well as your student body, and where do you fall on this scale? So in terms of recommendations for your institution, really look at curriculum development, look at the inclusion of cultural and linguistic competency, look at implicit bias and concepts of trust building. It will make you a better provider or public health professional when you leave this institution. Focus efforts on community outreach, especially for your most vulnerable populations. I was just meeting with Dora and we talked about all the amazing things that UNE is doing in terms of, clinics in our refugee areas. That was, again, another category of people that were very, very high in terms of being, where healthcare providers held bias was immigration status and refugee. So reaching out to these populations as an institution and prioritizing diversity in the classroom. And having a recruitment plan, having a retainment plan for your diverse populations. As an individual, what you all can do, please take the implicit bias tests. Learn the fundamentals of cultural and linguistic competency. There's a National Center of Cultural Competency. Fabulous. They have tools where you can assess, your level of cultural and linguistic competency by asking some questions. Not bias, your ability to interact in cross-cultural communications and dialogues. And try to keep up and understand the emerging science around health disparities. This is a field that's been here for decades. It really started to build momentum in the 80s when Margaret Heckler released a report for that, at that time for the administration that really looked at the differences in black and white, and that body of science and research is just expanding for other populations that I mentioned. Please integrate this work as faculty into your classroom, this new emerging science, as well as take it as your own personal responsibility as people going out into the field to try and understand what is going on with our most vulnerable populations, what are their risks, and how can you partner with them to empower them to find solutions to address those issues. Thank you very much, and I'm not sure if I have time for any questions, Dora.
So does anyone want to ask a question? I'll hand you the microphone.
You said in your presentation that education increases awareness, and there's some studies that show that, and then you said, and we hope that that changes your behavior. Are there any studies to show that that does change our behavior and that we do start writing more prescriptions for underserved people and things
There
like
have. In other fields, we see it a lot. A lot of this work has been done in the criminal justice system and the educational system. So what we have seen in those situations where absolutely, when you become more aware of your biases, and there's a researcher, his last name is Powell, P-O-W-E-L-L, who's done a lot of research in terms of the education increases the awareness and how does that translate in, a change in practice. So yes, there are some studies in terms of healthcare, but a lot of that research has been focused around the educational and criminal justice system.
I'm curious as to whether or not there's any tools for those that know they fall within a health disparity that would help empower. So are there rubrics or things that would help people move themselves as an advocate through the system?
It's interesting. We have done a great deal of work both in our refugee community and our American Indian community to try and address those issues of community empowerment. I will tell you, one of the best models that we've used in state government working with vulnerable communities is the idea of engaging in community participatory research projects where they take the lead. The community identifies the problem, and the educational institution helps work with that community to provide them with the technical expertise. But that model is really geared and focused and states very clearly that the expertise and knowledge is coming from that community. And I know when you approach things in that way, the work is so much more worthwhile. And we've had great experiences with that within state government as well as in other academic institutions. Sure.
Are there any data on people with disabilities?
Yes, yes. So please, this implicit bias test that you can take, it looks at other groups and categories of populations that we know those folks have been historically discriminated against in some way, as well as have huge disparities. And so it's well documented, people with disabilities having disparities, people with mental health diagnosis in particular having much shorter length of life, similar to the American Indian statistic I gave you. And so we know that is one of the categories on that implicit test where you can take and see where you fall in terms of your attitudes in working with and in interacting with people with disabilities. I work with an individual who is an expert in health disparities. This woman is a walking encyclopedia, and she works with vulnerable communities. This is her thing. And she was shocked at the results from the disabilities implicit bias test that she took. So it's quite interesting. Even when we think we're all good people, we're here to help people, and we're in healthcare, what our experiences and the environments that we grew up have done to the way we view certain categories of people. And I will tell you, the research states that we develop racial biases before we can talk, 2-3 years old. So this is not blaming, the minority, not minority, you should be able to get over it and trust or not trust. It goes far beyond that. This is really social science and how we navigate through the world and learn from media as well as other systems that come into play in terms of how we view certain categories of people. Please.
I just want to thank you for bringing this to the attention, and for people who are interested in another resource, there's a book that some of you may have read, The Immortal Life of Henrietta Lacks. Yeah. That's a marvelous story with historical perspective, The Immortal Life of Henrietta Lacks.
Thank you for bringing that up. It's actually been mentioned quite a few times. Another book I'd encourage you to read is Seeing Patients. And Seeing Patients is really about this issue about implicit bias. It's very new. It was just released in 2012. And it goes beyond that original study that Harvard did. But it is a Harvard researcher that developed that book as well. Anything else? We're good?
I think we're good. If people want to come up, and do you have a few minutes for individualized questions?
I will also say that Maine CDC as well as we love students, and we work with a lot of community-based organizations. So if you have a school project or need a placement and you are interested in this area, please talk to us, because we definitely want to engage. We truly believe this. I mean, we love you faculty, trust me, but we believe the students are really the ones who are going to tackle this issue of health disparities in a way that we can't as either administrators or faculty. So please be engaged with us as we move forward.
Thank you.